So next, we will move into the question of what treatments are recommended by the NIH for outpatients with mild to moderate COVID-19. In the past segment, we reviewed this slide. So for the treatment of mild to moderate COVID-19, focusing on the center here, one will be looking at approaches that will reduce the progression of illness or the numbers of hospitalizations or attended medical visits. And during this phase, one will note that we are not trying to dampen immunity, trying to reduce the good immunity that results in recovery in the majority of individuals. Rather, if we can optimize immunity so that patients do not move into the dysregulated phase of ARDS, that would be great. Or one can use antivirals. Now, there are a plethora of agents that if you put it in vitro in a lab, it will do something to either the immune system, or it might inhibit some stage of the viral life cycle. But that doesn't mean just because it works in vitro that it will work in vivo. So the summary of treatments as of today, or the time of this recording, and I must caveat that things may change by the time you're listening to this if the NIH makes an update. But at the moment, there are several therapies that do have in vitro activity against this virus or other rationale, but are not recommended for a variety of reasons. They include hydroxychloroquine, lopinavir, ritonavir, azithromycin, all of which were deployed early on during this pandemic. However, subsequent trials have just not borne these out. Dexamethasone for outpatients, we'll discuss in a moment, should not be given. And there are a variety of investigational agents that are really unclear as of yet. There's one study that looked at convalescent plasma for outpatients that was successful, but it was deployed very quickly to high-risk individuals, a study performed in Argentina. One can give interferons to try to stabilize the immunity early and perhaps overcome interferon defects that are going on. Ivermectin has been proposed as both an antiviral and immunomodulatory agent, and there are a variety of other potential repurposed medications, even anticoagulation early on. But as of now, there's no definitive trial that proves any of those therapies. And so NIH recommends, particularly for outpatients, the three combinations or single antibodies shown here: the monoclonal antibodies bamlanivimab, etesevimab, casirivimab, imdevimab, or sotrovimab. Why are certain therapies not recommended? As mentioned, in vitro activity, theoretical rationale may not matter in the end. One must look at randomized controlled data to really understand whether they would work. So here you're seeing a visual abstract of over 200 outpatients with confirmed SARS-CoV-2 infection who were randomized to zinc, vitamin C, or both. And one might say, well, these are very benign interventions. Why not give them to everybody? Well, unfortunately, when you give that in a randomized fashion, one doesn't really see significant differences in outcomes. And so based on this study, it's hard to recommend giving zinc and vitamin C as part of a cocktail to outpatients. And as mentioned, there are already trials disproving hydroxychloroquine, lopinavir, ritonavir, azithromycin, et cetera. And then looking at the long list, I should say, of potential interventions that may optimize immunity or have antiviral properties and inhibit the virus in vitro, there are hints of efficacy, particularly for, say, maybe colchicine, fluvoxamine, inhaled steroids. But these trials were not definitive. They were either preliminary and didn't include enough patients. A couple of the trials had missing data, or they have a really high number of what we'd say needed to treat to prevent a hospitalization. And for these reasons, I would say that if you can, and if a patient is particularly inclined, one should refer patients in the outpatient setting to randomized clinical trials. There are a number that may be close to you in terms of a center. There are also many that are mail order in nature, and conducted in a completely remote fashion to make it convenient for patients. One important take-home message is to avoid systemic corticosteroids for outpatients. The timing is really off. If one thinks about the stage of infection, this is before the immune dysregulation has set in. And really, you're trying to optimize immune responses and not impair or delay them, which may result in viral dissemination and making things worse. I want to look at this observational study from the Global Rheumatology Alliance in patients with rheumatic diseases. If one focuses on the plot here, where an adjusted odd ratio above 1 would be associated with a greater risk of hospitalization, one can see the usual risk factors such as age and comorbidities. But importantly, one sees that with prednisone, that if one had greater than 10 milligrams a day, it was associated with a greater than 2 times risk of a hospitalization. Now, a year ago, we heard that dexamethasone was good for inpatients with COVID-19 on oxygen. But since then, there has been a detectable increase in outpatient prescriptions for dexamethasone in our country. And so this is linked to that report, at least temporarily. But one should remember that it has not been proven and in fact may be harmful in the outpatient setting. So a number of studies have looked at monoclonal antibodies, which are generated against the SARS-CoV-2 spike protein and have been studied for treatment and prevention. So think of these as products that may provide passive immunity that for patients who have not yet developed these antibodies. And so emergency use authorizations have been issued for 4 different either single or double combinations for patients within 10 days of symptom onset. And they are listed here. One of them has been revoked, and we'll talk about that in a moment. But there are 2 combinations that have been in use for several months. And just last month, the FDA has issued a new emergency use authorization for sotrovimab. There's been a consistent positive effect where early administration of passive immunity in this fashion on disease progression, and it reduces hospitalization by about 70% in these randomized trials. So one can also worry about variants, which is a hot topic in COVID-19. Will they reduce efficacy? Well, yes, they might in the lab. As of now, we don't know whether the significance of these findings, but nonetheless, because of concerns about escape of the virus from antibodies, the bamlanivimab monotherapy arm EUA has been revoked. Now, one would note that the single antibody sotrovimab targets a highly conserved area of the spike protein, and thus right now may be used as a single agent. Whether one will need combinations if there's further variation in the spike protein in the future remains to be seen. Now, I don't want to go through this whole list about how we should apply these monoclonal antibodies, but I would point out this website, which is useful in finding a center near you. And the important thing is that patients should be administered these therapies earlier, that it makes sense that abrogating with antibodies early within the first days of infection is important. And while the window is up to 10 days for logistical reasons, really one should be focusing on administering to patients early. I'm listing the high-risk criteria for adults here, which you may look at, which makes sense based on the natural history of COVID-19. There are separate criteria for children. So by summary, for right now, we don't have a pharmacologic tool to prevent development of COVID-19 after exposures. We do have one major tool we're deploying in the United States, monoclonal antibodies for high-risk outpatients. And otherwise, we provide supportive care. Generally, one should stay on the medications, as there are reasons why patients are on these outpatient medications for other conditions, and abrupt withdrawal may be harmful. And there are some therapies one should avoid based on data. And there are hints of efficacy of some other outpatient therapies, but we are awaiting definitive trials. I would emphasize the importance to refer to those clinical trials. Again, that is the only way that we have learned about COVID-19 and how to treat.